Hi, everyone, and welcome to the 2020 PI. Sorry that we started a few minutes late. We had a little bit of technical difficulties, but we are all ready now. So I'm going to start by saying my name is McKenna Kresley, and I will be your moderator for today's session on Hyper IgE syndrome. I am excited to welcome Dr. Himal, who will be presenting this topic. There will be time for questions at the end of the presentation. Please submit any questions you have to the presenter in the Q&A section of the platform. Dr. Himal is the Elizabeth Page Levine Endowed Chair of Immunology Research and Clinical Care Fellowship Training Program Director at the Children's Hospital of Philadelphia and Associate Professor of Clinical Pediatrics at Perelman School of Medicine at the University of Pennsylvania. She received her MD from New Jersey Medical School, where she also completed her internal medicine pediatrics residency, followed by fellowship training at NIH. She is vice chair on the Quad AI Primary Immunodeficiency Committee and a CIS counselor. She is the PAG liaison for the Primary Immune Deficiency Treatment Consortium and co-lead of PIDTC's current SCID study. She's the clinical director of the CHOP program for integrated immunology and cellular therapy. Her clinical research interests includes atopic dermatitis and immunodeficiency, newborn SCID, and long-term outcomes of hematopoietic stem cell transplant for immunodeficiencies. Thank you for joining us, Dr. Himal. And with that, you can share your screen and get started.
All right, thank you so much for that really kind introduction, and I'm really happy to be here with all of you today. Let me just get myself sharing. Am I sharing appropriately?
Yes.
Okay, so I'm gonna go off to the races. Let's see. There we go. These are my disclosures. And so I think before talking about Hyper IgE syndromes per se, it's probably useful to go over what IgE actually is. So IgE is one of the 4 types of immunoglobulin. So we know that we make from our B cells IgG. That's what we get replaced for patients who are receiving IVIG. They're only getting IgG. We have IgA, which is kind of a secretory immunoglobulin that usually lines mucous membranes and can be secreted in things like mucus and breast milk. IgM is a larger immunoglobulin molecule, and this immunoglobulin is important because it's the first immunoglobulin that is released in response to an acute infection. But our area of focus for today is to really talk about IgE and in states where you might see an elevated IgE level. So what are some of these states where we would see a higher IgE level? The most common situation to see a high IgE, and it can be in like the 10,000, 40,000 range, is severe eczema. Also patients with allergies. But then we start to get into some less routine things like parasitic infections, a lung condition called allergic bronchopulmonary aspergillosis, or ABPA for short, allergic fungal sinusitis, patients with new onset HIV. It can be elevated in the setting of having lymphomas or other cancers. And then what I think we really will focus on during this period of time is talking about how we see high IgE in association with combined immunodeficiencies and the so-called hyper IgE syndromes. But I would not be doing a good job if I didn't tell you about what IgE does and why we always see it as being so high in kids and adults who have significant allergies and significant eczema in particular, or atopic dermatitis in particular. So IgE is an immune protein that becomes specific to things that otherwise are harmless in the environment. It's kind of a misdirected danger signal to something like peanut. And so unfortunately, your body then starts making a lot of IgE specific to peanut. And then when you get exposed to peanut again, that peanut is able to allow cross-typing of your cross-linking, of IgE molecules that then would bind to the surface of a mast cell. Mast cells are the mediators of allergic disease to cause symptoms that we think of as allergy. So hives, itchy skin, sneezing, a runny nose. And in more severe cases, let's say you had a lot of exposure to this peanut that you're allergic to, vomiting, leaky blood vessels, and anaphylaxis. So I want to spend just a couple minutes on kind of scientifically what causes IgE to be high in general. And so this is a really nice diagram. I know it's old. It's hard to think of 1999 as being old, but it is. But this pathway still is what's going on. So what happens is that if you have an antigen presenting to a B cell through the CD23 marker, we can then see stimulation of that B cell to make IgE. But what led to the B cell being primed to make IgE really happens down here in this interaction of the T cell with the B cell. So when T cells are exposed to protein stimulus, if it's a very strong signal of stimulation, this will usually cause more of a beneficial inflammatory reaction and sometimes an overexuberant inflammatory reaction that will also tend toward making something called interferon gamma. Interferon gamma, when you secrete it, suppresses the production of IgE. But when you don't have as strong of interactions, we see more production of the allergic type of cytokines, in particular IL-4, IL-13, are what are the mediators to then allow through the IL-4 receptor the drive for B cells to make more IgE. When we don't have good interactions, good strong interactions, that's when a weaker signal tends to lead to more IgE production. And you can see this is just looking in allergic individuals that throughout the lifespan, the IgE levels that are seen in patients who have allergy can be, twofold higher than what you would normally see in a non-allergic person. And this is why we say that the most common thing that will cause you to have a markedly elevated IgE is to have significant underlying allergy, more so than any of those other conditions I mentioned on the last slide. But what about IgE in immunodeficiencies or immune dysregulation? So these listed here are diagnostic criteria for combined immunodeficiency. And I think it's very easy to think of severe infections, especially something that causes a patient to unfortunately be hospitalized, as being a sign of immune deficiency. I think increasingly we're all aware of autoimmunity, like having low autoimmune cytopenias or autoimmune neutropenia, thrombocytopenia, or low neutrophils as being a sign of immune dysregulation. Inflammatory bowel disease is a sign of immune dysregulation, having unexpected lymphoproliferation. But one of the things that I think we need to focus more on is that very severe eczema that doesn't respond to typical therapy can be a manifestation of a combined immunodeficiency. And so that's why we always want to, if you have a patient or you or someone with severe eczema, it makes sense for us to check and make sure there's not then laboratory evidence of having an immune deficiency. And toward the end of my talk, I'm going to go over some of the kind of recommended screening labs one could do, or you could talk to your doctor about to help figure out if having a high IgE level is from an immune deficiency or immune dysregulatory disorder versus simply being associated with having significant allergy. So when is high IgE a problem? I don't know if anyone's a Schitt's Creek fan, but this is one of my favorite memes. Anyway, so the things that might make you think of a high IgE being syndromic as if it starts very early, like kind of in the first couple of weeks of life. If you or someone you know is having trouble with significant skin infections that are in particular things like warts or molluscum or severe herpetic infections, or having trouble with mucocutaneous candidiasis or skin fungal infections. Those are some red flags. Significant connective tissue differences, so being very flexible, having more fractures, brittle bones, that's a red flag. Autoimmune diseases, like I kind of mentioned, are a sign. Failure to thrive or poor growth. And then certainly if there's other family members who have some of these things, plus a high IgE, that makes us think about genetic differences that could be causing a hyper IgE syndrome that's more than out. But to add to the confusion of this, there are people with syndromes that are associated with high IgE who have a normal IgE. I have quite a few patients who have some of the immune deficiency syndromes that I'm going to highlight, who did not have significant eczema as their first presentation and did not have a high IgE. So, not every patient with immune deficiency that should be associated with IgE truly has high IgE. And lots of primary immunodeficiencies as part of the disease can be associated with a high IgE. So it can be helpful for us to think in the categories of immune deficiency, what are some of the interactions or the differences that might lead patients to have high IgE? So certainly if your skin or your gut doesn't work normally to keep an intact barrier, the ability of allergens to kind of leak through or infectious agents to kind of leak through because of having some differences in those types of cells can be associated with genetic forms of having high IgE. We also see this in patients who have altered cellular metabolism, in particular, the ability to appropriately transport glutamine because of differences in the PGM3 gene. This will decrease their T cells function through decreased mTOR signaling. I already mentioned, but if you have an inability to make a good, strong communication between T cells and antigen-presenting cells, either because of pure antigen-presenting defects, decreased antigen receptor signaling, or cytoskeleton defects, all of those things that can contribute toward T cells being more likely to make IL-4 or IL-13, and that then down the road leading to your B cells making more IgE. And then finally, kind of the biggest category of differences that we see are people who have a challenge to signal appropriately for some of their immune cytokines, and that they might signal too strongly for the so-called atopic or Th2 cytokines of IL-4, 5, and 13. So just to kind of go over where some of these defects fall, if we have impaired T cell receptor signaling, so any of the so-called BCM signaling pathway defects, CARD14, CARMEL2, and ZAP70, these all will impair T cell receptor signaling, as will genetic variants that are, only partially causing a deficiency in genes that otherwise are known to cause severe combined immunodeficiency. All those things will impair T cell production or T cell signaling. There's one known genetic defect of antigen presentation, but the bigger categories of disease that I will spend a little bit more time talking about are defects in cytoskeletal ability of the cytoskeleton, which is kind of how the architecture inside your cell works to be able to allow T cells and B cells to make synapses to tightly talk to each other, and T cells and antigen presenting cells to make synapses and talk to each other. So one of the most classic immune deficiency syndromes that can be associated with high IgE was one of the first ever to be described, Wiskott-Aldrich syndrome, and the associated other genetic differences in that same kind of pathway. We also see this with DOCK8 deficiency, is that it's really related more back to cytoskeletal impairment. And then that impaired cytosignaling group, I think, most people, when we say hyper IgE syndromes, think about Job syndrome. And Job syndrome is kind of one of many defects of the STAT3 and IL-6 pathway, which I've listed here, and I'm going to talk about Job syndrome in a little bit more detail. We also see that differences in TGF-beta signaling, which is a growth factor for T regulatory cells, can lead to high IgE-associated immune deficiencies. The IPEX and IPEX-like group of cytokine signaling differences can cause this, higher IgE. And then finally, there are a few, other defects that don't fit neatly into one of those categories. So JAK1, TBX21, and STAT6 gain of function. All of these can also be associated with elevated IgE and sometimes allergic symptoms to go with it as well, in addition to the immune deficiency features. So the first HIVE or hyper IgE syndrome is, Job syndrome, named after the biblical character Job. But this syndrome was first defined by Dr. Becky Buckley back in 1972. And that kind of coincided with the recognition of, ability to measure IgE. And what she described this to be is the hyper IgE recurrent infection syndrome, with a classic triad of the patients that she had found who had eczema, recurrent cold boils. So early on, already seeing that there was some difficulty in mounting a typical inflammatory response, and that these patients also had significant trouble with pneumonias that would then cause structural lung challenge because the body's ability to contain infection wasn't as good. So unfortunately, patients that she saw would develop pneumatoceles or kind of cavitary lesions in the lungs or bronchiectasis. And then there were also connective tissue and skeletal system differences. Since then, in addition to STAT3 loss of function, we've also now described as an immunology community that other signaling molecules that are dependent on STAT3, like ZNF341, IL-6ST, and the IL-6 receptor, have a very similar clinical presentation. So there can be mimickers of the classic Job syndrome. But what are the symptoms we see? So really significant eczema with recurrent staphylococcal-driven symptoms and infections. Patients with significant difficulty with mucocutaneous candidiasis and invasive fungal infections. But a big important differentiator for Job syndrome and the IL-6 STAT3 pathway differences is that we don't tend to see the primary viral infections like we see in the cytoskeletal forms of hyper IgE syndromes. And the other thing that's a big difference is that because STAT3 is important for those mast cells that are important mediators of allergy to do their job, you don't tend to see anaphylaxis despite having IgE that is specific for certain allergens in many patients who have Job syndrome. Other common features are frequent fractures that happen very easily. So, I had a patient once who was walking down their driveway, rolled their ankle over, just kind of, there was an acorn and they rolled their ankle and ended up with a fracture of their lower ankle. People with retained childhood dentition. So you can see in this picture, this patient has normal, healthy adult childhood teeth, and there are adult teeth wanting to find their way forward and they just can't. There's also joint flexibility. There's some typical facial features, and these patients can have increased risk of autoimmune diseases or lymphomas. So there is a scoring sheet that can be used. I think more and more people do tend to go straight to genetic testing, but I know sometimes that's not an easy resource. What we tend to say is you might have Job syndrome or one of the STAT3 pathway differences if the IgE is over 1,000 and there's a Job score system score greater than 30. But if there's a family history and a lack of a specific kind of T cells that are important to prevent fungal infections called the Th17 cells, if you have those things and the score over 30 and an IgE level over 1,000, that is what makes us think that it's probably really Job syndrome. And then certainly if you have a mutation in the STAT3 gene, then that's a definitive diagnosis, that's for sure. This is an old paper, but I think it's really, really helpful, so I like to include it still. This was a paper that Ellen Renner put together looking at the differences of clinical presentation of patients who did have STAT3 mutations or variants that were pathologic versus those who didn't. Presumably those who were more allergic. And what she found is that that having a high IgE was pretty much seen equally in the two populations. And so while it was very sensitive, if you have an IgE that is, more than 10 times normal, you're almost always going to pick up a hyper IgE patient, but it's not a very specific marker, so you can't really hang your hat on it. But if you have that, plus a patient who has abscesses or structural lung abnormalities or severe infections, the skin and fingernail mucocutaneous candidiasis, minimal trauma fractures, scoliosis, and a relatively low rate of having allergy, those things had much more of a specificity. They were more likely to truly be someone who had hyper IgE due to differences in STAT3. Moving on to a different kind of cytokine pathway signaling defect, IPEX, which stands for Immunodeficiency Polyendocrinopathy with enteropathy X-linked. So this disease occurs due to X-linked mutations in the gene called FOXP3. And FOXP3 is very important for your body's ability to be able to make T regulatory cells, which help shut down your T cells to help avoid autoimmune problems. And so as an extension, because of that, these patients have difficulty with early onset of type 1, the autoimmune diabetes that is insulin dependent, very early onset of enteropathy and severe eczema. And then they can also have these other body systems be impacted by autoimmunity. But interestingly, they also can experience food allergies and asthma. When we look at labs in these patients, we often do see a very elevated IgE, high eosinophil counts, which often are, both of these things are commonly seen in allergy, but the big differentiators that we see is that we may start to see autoantibodies be present, which are not usually a feature of allergy. We can see normal to high white blood cell counts and lymphocyte counts. And then the real clincher for the diagnosis, short of genetic testing, is to really look for T regulatory cells and see if they may be absent. And then finally, if your physician has access to measuring cytokine level, these patients will usually have high IL-4, 5, and 13 and lower interferon gamma. We now know that there are both IPEX and IPEX-like syndromes. The IPEX, the patients who truly have IPEX do tend to have a higher IgE level, as you can see from this diagram over here. So this bar up here is higher in the IPEX patients and lower in patients who have IPEX-like disease. And then, but what you can see is many of the clinical features are very similar. So you really need the laboratory features to help differentiate what sort of disease you're actually dealing with. And it matters because different forms of these IPEX versus IPEX-like syndrome will respond better to different therapies, in particular, the use of biologics or the use of certain immunosuppressants, in particular, JAK inhibitors. Moving on now to some of those cytoskeletal rearrangement differences that I had mentioned. So Wiskott-Aldrich syndrome is another X-linked immune deficiency that, in addition to having significant eczema and allergies, the patients unfortunately suffer from significant autoimmune cytopenias, vasculitis, and colitis. There can be significant difficulty with susceptibility to herpes viruses in patients with Wiskott-Aldrich syndrome because their natural killer cells don't work as well. And they have significant trouble with bruising because they have low numbers of platelets that are smaller in size. So what we see when we do laboratory testing is having a microcytic, small cell size thrombocytopenia, so small platelets that are small in size and lower in number than we expect. Over time, most patients who suffer from Wiskott-Aldrich syndrome have a progressive loss of their T cells, and the ability of those T cells to be activated to a stimulus or a mitogen is impaired. There are usually reduced number of B cells, and the NK cells, although typically high in number, unfortunately don't do their job well because they are very dependent on the actin cytoskeleton to be able to make an effective immunologic synapse. So this was a study done, almost 9 years ago at this point, but just kind of looking in general at the different categories of patients, the general population, patients with Wiskott-Aldrich syndrome, patients with X-linked thrombocytopenia, and patients with atopic dermatitis. And what they found is in this study that patients who have X-linked thrombocytopenia, which is associated with genetic differences in the Wiskott-Aldrich gene, have very high rates of food allergy. It's higher also in patients with Wiskott-Aldrich syndrome per se than the general population, but not quite as high as the general atopic dermatitis. And then if you kind of look at what types of food allergies were seen, there was no real difference. There was one particular group that was more present or not in terms of which foods were affected. In terms of thinking about the Wiskott-Aldrich syndrome, I just would point out that there is this Wiskott-Aldrich score that was developed about 15 years ago. And it's important to realize that patients, this is really more of a score and a continuum of disease. And so at any point, a patient who has X-linked thrombocytopenia really can develop symptoms that would be considered consistent with classic Wiskott-Aldrich syndrome. And so it's important that we always be vigilant and we can think differently about how we might approach patients with X-linked thrombocytopenia to try to prevent severity of disease. So other related syndromes to Wiskott-Aldrich include X-linked thrombocytopenia, like I mentioned, which is associated with the thrombocytopenia and an increased risk of food allergies. There's also X-linked neutropenia, and this disease is slightly different because it's more of a gain of function in the Wiskott-Aldrich protein, but these patients do still have high IgE and an increased risk of food allergy. And then the Wiskott-Aldrich inhibitory protein, in this disease, if you have mutations that completely interrupt function, the patients will be just as sick as patients with Wiskott-Aldrich syndrome. And ARP-C1b is also a very important protein that helps with the cytoskeletal rearrangement function that Wiskott-Aldrich protein does. And so if you lose the ability of this protein to do its job, you see similar symptoms as what we see with Wiskott-Aldrich syndrome itself. Moving on to another cytoskeleton rearrangement difference in DOCK8 deficiency. So this is an autosomal recessive disease, meaning that affected patients need to have two genetic differences to have manifestations of disease. These patients have severe, often, bacteria, staphylococcal-driven eczema with a lot of redness to the skin. These patients have food and drug allergies and have anaphylaxis there, so they're severely symptomatic. But in contrast to the other syndromes that we've talked about, the rates of skin viral infections are very high. So we see a lot of warts, we see a lot of molluscum, and these images are from kind of the initial paper describing this disease back in 2009 of the warts that some of the patients had experienced. There's also an increased lymphoma risk. And when we do labs, what we see in patients with DOCK8 deficiency classically is a very high IgE with a low IgM and a variably different IgG. The patients usually have high eosinophil counts with low lymphocyte counts and low Th17 cells, which are those cells that are important for fighting against fungal infection. What has been described to be very effective in the treatment of DOCK8 deficiency is transplant. And so this is just a really beautiful representation of the clinical improvement that this child experienced, and which is published data. And then this is also another patient's wonderful clinical improvement after having received transplant. We obviously don't do transplant to improve the eczema. That's not the main indication, but this is just an outward sign of the efficacy of transplant for these patients. So when is having high IgE a syndrome? I hope that I've been pointing out that high IgE can be caused by lots of stuff. It can be caused by a genetic difference. It can be driven by having environmental allergen and food allergen exposures. It can be driven by having infections, but it is most commonly driven by having severe eczema and other allergic disease. Even when it's super, super high, that's not meaning that there's an immune deficiency. Sometimes there's a genetic difference, but a lot of times there's not. And sometimes there are people who look like they probably have one of these syndromes, but we haven't, but when we do genetic testing, we don't find that they have that gene that's been described before. What we would usually do in that situation is treat the patient with the same supportive therapy that we would if we had found the gene, and then we can continue to look on an exploratory and research basis for related genes. Because I think one of the other things that I have been trying to point out during my talk is that, for like Job syndrome is a perfect example where we started with a bunch of clinical symptoms and named a syndrome. Then, like 35 years later, we found the first gene, the STAT3, difference. Within the 10 years since STAT3 was described, three more genetic differences that look just like it because they're in the same signaling pathway have been described. So if a patient with a STAT6 signaling problem had been tested genetically back in 2007, we wouldn't have found anything because we didn't know, we would have looked for STAT3, but we wouldn't have known to look for IL-6 yet. It was by participating in research and clinical trials that was then discovered to be a new way to have the same symptoms happen. So what do we clinically recommend for, to do when we have patients? Is what I do in my clinics. We start with very basic investigations. We start with a simple, CBC, which is a cell count, and we pay a lot of attention to the lymphocyte count and the eosinophil count. We look at all the immunoglobulins, IgG, IgA, IgM, and that should be IgE. We look at tetanus and pneumococcal titers, so responsive to vaccines, assuming the patient has been vaccinated. We would culture the skin for bacterial, fungal, and viral pathogens because that can give us a clue to think about whether there's different, what's more likely. We also will do spit culture or sputum culture. And then we look at the lymphocytes, and we first just get basic flow cytometry to get a sense of, do you have normal numbers? just from the baseline of T cells, B cells, natural killer cells. But then once we've done that, and if it looks normal, which it does in many of these diseases, then we have to do these advanced kind of assessments. We look at how well the immune cells can divide and grow in response to specific stimuli. And then, increasingly, one of the first things we will do after we are even at this point, rather than necessarily going to this advanced assessment, is do an immune deficiency panel. But the big caution I would say here is you don't want to limit your testing to doing the what are marketed as Hyper IgE syndrome panels. We usually just go ahead and get larger immune deficiency panels that include a really broad range of both combined immunodeficiencies and the more traditionally thought of Hyper IgE syndrome. And then in terms of a practical approach to management, for many of these disorders, hematopoietic stem cell transplant is a treatment option. So in the defects of antigen presentation, all the defects of cytoskeletal impairment, all the defects with impaired TCR signaling, successful transplant has been described in at least case reports, if not larger populations. But even before transplant, most of these patients do require pre-transplant supportive care with things like prophylactic antiviral, prophylactic antibacterial, antifungal, and anti-pneumocystis drugs, and immunoglobulin replacement. There are also increasingly reports of in many of these diseases using dupilumab, which blocks both IL-4 and IL-13 signaling, or omalizumab, which binds IgE to control the allergic symptoms before transplant. And then within the impaired cytokine signaling defects, this is where things become a little bit left toward the immediately go to transplant sort of side of things. And I think this is because the cytokine signaling defects are not just going to impact on immune cells. And so the most common, reports of how patients have been managed are with using supportive therapy, either the same as what I described for the other disorders, but also using things like dupilumab, JAK inhibition to decrease the inflammation, or other immunosuppressants or immunomodulators. Transplant has been used for FOXP3 associated IPEX disorders, STAT3, both gain of function and loss of function, and STAT1 gain of function, with variable success in each of those types of disorders. So my take-home message is, and then I'm happy to answer questions that you all may have, is that IgE can be elevated for a lot of reasons. It can be high in people who have a syndrome, an unknown syndrome, or it could just be that you have significant allergy. There's lots of increasing numbers of genetically testable immune deficiencies or immune regulatory disorders that as a prominent feature do have high IgE. And so I would recommend that if on testing you're found to have a high IgE, you would talk with your doctor to think about whether additional testing makes sense. And then the management really varies depending on which of any of those greater than 30 different genetic disorders you're dealing with. So it really has to be individualized to a given patient and their individual symptoms. And with that, I'm happy to stop my share and I'll take any questions that you all have.
Thank you so much, Dr. Heimel, for providing that overview.
Yep.
We now have some time available for Q&A. Before we begin, please remember that everyone's treatment and condition are unique. The information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health providers with questions concerning a medical condition. So with that, we've received some great questions, so I'm just going to go through and ask them. So the first one is, if my child was diagnosed with Hyper IgE syndrome, what are the chances that I could have another child with high IgE? Is it common for it to exist among siblings?
Sure. And so the answer to that question really varies depending on what genetic form of Hyper IgE syndrome your child has. So I'm going to give two examples and then say that you probably have to talk about your specific situation with your own personal doctor. But if you're talking about kind of the classic Job syndrome, which is due to autosomal dominant loss of function protein mutations in the STAT3 gene, if one child is affected, what we usually recommend is to test the parents and know if they have the gene as well. It's usually not the case that the parents have that gene, and that if they're asymptomatic, and then that this genetic abnormality happened de novo or occurred spontaneously in a child, in which case other children would not be likely to have this disorder. In the case of something like IPEX syndrome, where it's an X-linked disease, it is possible for moms to be, X-linked diseases are usually inherited from mom because women have two X chromosomes, and men or dads have an X chromosome and a Y chromosome. So X-linked disorders usually manifest in boys whose moms were a carrier. If that is the case, so in pretty much in any disease, we recommend to test the parents to know if parents are carriers. In the case of X-linked diseases, if a mom is known to be a carrier, we know that in every pregnancy, 50% of her male children would be likely to be affected, and in every pregnancy, 50% of female children would be expected to be carriers. And then finally, to talk about an autosomal recessive disease like BAC8, in this sort of hyper IgE syndrome, usually there would need to be two genetic differences, because autosomal recessive means you have to have two abnormalities in the gene. And the most common way this occurs is that one is inherited from the mom and the other one's inherited from the dad. In any of these disorders, there can always be a spontaneous difference that arises, and that's why we recommend to check the parents. But assuming both parents are carriers, with every pregnancy in that situation, there's a 25% chance of having another affected child and a 50% chance that any child would go on to be a carrier of the disease.
Okay, great. That's awesome information to have. This next question is kind of related to that last question.
Okay.
And it's, when you talk about genetic testing, what do you recommend? I've heard about whole genome sequencing and whole exome sequencing, but I don't understand the difference.
Sure.
Where does 23andMe come into play into all of this?
Sure. So what I would say is I would generally recommend to use panel-based genetic tests that are optimized and have been tested to have an appropriate ability to detect the genes that they say they're going to detect for immune deficiencies as a first step for genetic testing. After that, when you think about something called whole exome or whole genome-based testing, what you're really talking about doing is whether you're going to look at when we think about the DNA in our body, it's broken out into introns and exons. And exons are the parts that usually form most of the coding material that go on to make proteins in your body. And that only comprises about 3% of your total genetic material. But because it's where most of the differences that could cause disease come from, that's why we will sometimes do whole exome testing first. Increasingly, we know that differences within the intronic regions, so those introns, can impact on how you read an exon and may change how much certain coding is turned on or turned off. And so if you do whole genome sequencing, you're looking not just at the exons, but the introns too. The challenge is you're looking at a lot more data, so it's more expensive, and you really have to know what you're looking for. You also have to be sure that the testing company that you're paying to do the test, again, really has the primers and is optimized to be able to detect what you think it's looking for. And so for this reason, I don't recommend using kind of the commercially available over-the-counter genetic testing, box type tests to be trying to screen yourself for, medical disorders. That you're probably better to use a medical genetic test.
Thank you for that great response.
Mhm.
The next question is, do you imagine there might be newborn screen testing for hyper IgE in the future like there is for SCID?
I think that's a great question. And I think it actually almost relates back to the last two questions.
Yep.
The best way we'd be able to detect or do newborn screening for all of those different 30 types of immune deficiency was if we did more genetic testing from birth. That obviously brings up cost and ethical questions that, it's not, I don't know that the newborn screening programs are yet able to take on that breadth of screening. What's also important to realize is when we think about newborn screening, there's kind of guiding principles for what kind of disorders are considered appropriate for newborn screening to kind of justify optimizing the test, subjecting patients to testing that may be more likely to cause false positives and the anxiety and stress associated with false positives. And then, of course, the cost to society of increasing testing on a population basis for large, distribution of diseases. One of the reasons that severe combined immunodeficiency was able to successfully advocate for newborn screening for that disease specifically is that there was a test that was very specific to detecting the lack of naive T cells that are kind of the primary feature of severe combined immunodeficiency. There was very clear data that by treating patients in the first couple months of life, there was a significant advantage to survival, and that if you didn't, there was a significant disadvantage that most patients with severe combined immunodeficiency would not survive beyond the first year of life. And even with those very compelling arguments, it was a long fought battle. So I am cautiously optimistic that as the cost of genetic testing comes down and as tests may be able to be optimized to reduce the risk of those false positives that could increase psychological trauma, there might be opportunity for newborn screening for more primary immunodeficiencies in general. But I don't think we're at that point yet.
Okay, great. This next question is kind of a scenario question, but it's along the same lines of genetic testing. So my son was diagnosed with hyper IgE syndrome and an IgG2 subclass deficiency at 5 years old back in 1988. He is now 40 years old and has been presented with classic Job syndrome. Should he get further genetic testing to determine more targeted treatment options?
Well, I mean, so what I would say is certainly what makes sense for him really depends on his clinical symptoms and his personal preferences. I would say if, in a patient who's 40 years old, and if they're presumably clinically doing well, one of the biggest advantages of considering genetic testing is for family planning and genetic counseling purposes to know if you are a carrier of that disease and what your risk would be to pass it on to future generations. In patients with STAT3 loss of function, Job syndrome, there is some evidence for using things like dupilumab if you're having significant difficulty with, some of the features of the disease, like the eczema. And there have been very rare, but some patients who have benefited from hematopoietic stem cell transplant. But, I think just hearing the age of 40 years old would make it seem less likely that there'd be a need for a transplant in that specific situation. But again, I'd really encourage to discuss that with your primary doctor who's managing the hyper IgE syndrome.
Okay, Great. And to finish out this session, we have one more question.
Sure.
So since patients with hyper IgE are often on prophylactic antibiotics long-term, is there concern for them to develop antibiotic resistance?
That's a great question. And it kind of varies depending on which prophylaxis we're talking about. So the pneumocystis prophylaxis, Bactrim prophylaxis, again, and it also depends on which hyper IgE syndrome we're talking about. So if you're on Bactrim at doses that are for pneumocystis prophylaxis, which is what we would usually do for a patient who is being managed for, say, Wiskott-Aldrich syndrome or one of the combined immunodeficiencies prior to transplant, we don't see resistance develop to Bactrim for pneumocystis. In contrast, if you're on Bactrim as a daily dose to try to prevent against staphylococcal infections, like would be the case for what we do in patients with STAT3 mediated disease or Job syndrome, we are increasingly seeing resistance to Bactrim and staphylococcus. So I think it really depends, and you'd have to talk with your doctor about, why you're on the given prophylaxis that you are. And what the risk of developing resistance is. But yes, across the antibiotic, antiviral, and antifungal medicines, in certain situations, there can be a risk of developing resistance. But usually my approach with my patients is we talk about kind of the risks and benefits. But in general, the benefit of avoiding the infection for many patients outweighs the risk of resistance. And if they do get infection, that's why we will culture, do resistance testing, and always use a different agent than what is being used for prophylaxis to treat what appear to be breakthrough infections, which we would then assume are probably resistant to what you have been on thus far.
And with that, our time together has come to an end. Thank you so very much, Dr. Heimel. It has been an honor to have you join us today. This session is just one of 39 unique learning opportunities provided through our 2023 PI conference. We hope you continue tuning in today as we explore other critical topics for the PI community. Thank you and have a great day.
Thanks. Bye-bye. Great to talk with you all.